phones on silence, everybody.
Hi, this is Jill Stevenson. I'm the patient navigator for the joint replacement program at Great Plains Health Orthopedics. I would like to introduce Dr. Evan Correll, who's one of our orthopedic surgeons. So I'm going to let you introduce yourself, tell us what you do, and a little bit about yourself.
Yeah, so I'm originally from North Platte, Nebraska. I grew up here, went to high school here. My wife is also from North Platte as well, and we still have a lot of family in the area, so that's why we came back here. Been working here now about 2.5 years, and have really enjoyed it. As far as the cases I do here, this talk will be mainly about hip replacement surgery. I also do knee replacement surgery, shoulder replacement surgery, basic knee scopes, shoulder scopes, as well as fracture work. I guess we're going to have a little question and answer session here, and Jill's got some questions lined up for us.
So if anybody watching has questions, type your questions in the comment line, and then we will ask him your questions. If we don't get it answered and you're watching it later, type your question in and we will have him answer later. So what is your favorite type of surgery to do?
Favorite type of surgery to do? My favorite type of surgery to do is the one that I know is going to help my patient. Now that being said, probably some of the happiest patients that I have in clinic are patients that have had a hip replacement, patients that have bad hip arthritis and pain from hip arthritis are, to be honest with you, usually pretty miserable before surgery, and they have a tendency to feel a lot better after the hip replacement, and our goal is to treat the pain without them knowing they ever had surgery, and a lot of times we can't do that with a hip replacement.
So how do I know if I need a hip replacement? What should I do?
So step number one, as far as if you need a hip replacement, is there's a lot of different things that can cause pain around the hip. A lot of different pain generators. Some pain is coming from the hip joint itself, and oftentimes that is from an osteoarthritis or a wear and tear process that's within the hip joint. Most of the time that pain will manifest itself as pain that's deep in the groin area, worse if you're sitting for long periods of time. Oftentimes patients will say they have difficulty kind of bending down, putting shoes on, tying their shoes, because that comes from the stiffness that comes along with the arthritis that develops in the hip. But step number one is to make sure the pain is actually coming from the hip joint. There's a lot of other pain generators. You can have pain coming from your back that's referred towards the hip. You can have pinched nerves in your back that refers towards the hip. You can have inflammation or bursitis that's not technically coming from the hip joint itself, that can be successfully managed without surgery. So as far as knowing if you need a hip replacement, when you need a hip replacement, step number one is we have to figure out exactly where the pain is coming from, and that's usually fairly easy to do. Just starting off some plain x-rays that we can get in clinic, see if there's any signs of degenerative changes within the hip, and then do a careful examination, and make the imaging findings correlate with the physical exam and history, and if we do all that and it does look like there's an arthritic process going on in the hip that's generating the pain, there's also conservative treatment we can do for the arthritis in the hip. Any kind of low impact exercises, weight loss, anti-inflammatories, using a cane, all that kind of stuff can be helpful. And when that stuff's not working anymore and the pain's progressive, then at some point we do end up doing the hip replacement.
Can you explain the different type of approaches for hip replacement?
Sure, yeah. So there are several different ways to do hip replacement surgery, and that's in regard to the approach, the surgical approach that's used. And that's basically how we get down into the hip to work on it. front, which we call an anterior approach. You can go in through the side, or you can go in kind of through the back. The main way that I do hip replacement surgery is through an anterior approach or going in through the front. There are pros and cons to each different kind of approach with hip replacement surgery. The main advantage of going in through the front is you're going between the muscles instead of, and you don't really have to release much of the muscle off the bone to get down there to work, and that usually helps patients have a little faster recovery, especially within the first 6 weeks. The other reason that I like to do an anterior approach hip replacement is we can position you in the operating room to where we can also use a live x-ray machine while we're in there doing the surgery, and that just helps optimize implant position, help more accurately reproduce leg length and offset, so that's the way that I typically do it. But there's pros and cons to every different approach that can be done for hip replacement. This is, can you see the models here? Can you see that for me? Okay. So this is what a hip replacement looks like. If we can see this on the camera here. So again, with an anterior approach hip replacement, we can kind of go in between muscles that are right here in the front, instead of the approaches where you have to take some of these bigger muscles down to get in there and work on the hip. It is a little bit more challenging exposure coming in through this way, and patients especially have bone quality that isn't the best. There is a little bit of an increased risk for fracture, but as long as the patient's a good candidate for it, we can go in through the front here, go down between the muscles, expose the hip. Once we get down to the hip, basically the worn out ball and socket that would be right here is removed. We make a cut right here on the bone to remove the worn out ball, and then that gives us room to work on the socket. We then take some special instruments that just shave out all the worn away cartilage and worn away bone until we have just nice healthy bone remaining in the socket, and we use an implant that has a special covering on it that the bone likes to grow into. And so we place this cup in here with a nice snug fit, and sometimes we put some screws into it if we need to help hold it. Usually we can just get in there with a nice snug fit, and then over the next several weeks the bone will work on growing into that metal implant. We then put what we call a polyethylene liner, which is basically like a fancy plastic material that acts as a bearing surface inside the socket. For the femur, we then have a stem that we put down inside the hollow portion of the thigh bone here, and we just again use some instruments that kind of reshape the top of the bone here, so that way it perfectly matches our implant. Our implant again has a nice snug fit on it. Once we get in there, this implant again is covered with a material that the bone likes to grow into. Then we put the ball in there, and we make adjustments so that we reproduce the leg length and offset that's appropriate for the patient. And then the pain that was coming from the bone-on-bone arthritis in the hip is eliminated after we get the new implants in there. So again, the implants are strong enough. They have that nice snug fit right after we put them in, so we can let patients, get up, start walking on it right away after surgery, and typically after an anterior approach, commonly see where patients use a walker for a couple weeks after the surgery, then transition to a cane, and hopefully by 4 to 6 weeks, getting away from needing any kind of assistive device. But everybody recovers at their own pace.
So what are the implants made of, and how did you decide which one you're using?
So the implants are, most of the implants are made out of a titanium material. They do have a few other options out there, at least when it comes to the stem and the socket. The polyethylene liner which again acts as the bearing surface inside the socket. That's probably within the last 20 years, that's the thing that's advanced the most for hip replacements to help with the longevity of the implants. And then the ball that we put on can either be a cobalt chrome material or a ceramic material.
So how do you do anesthesia with a hip replacement? Are you awake for surgery? Do you do spinal blocks? What type of anesthesia do you use?
So for the majority of our hip replacements and knee replacements as well, we do spinal, and basically that's just going to kind of numb you from about the chest down. The anesthesiologist will then also give you some medicine, so you're sleeping through the procedure. You don't recall what's going on. But in comparison to a general anesthetic, where you're sedated deep enough where you're no longer breathing on your own, they have to put the breathing tube in for you. The spinal anesthetic, it kind of numbs you, so they give you just enough medicine that you're sleeping, but you're still breathing on your own. And the advantages with that is that spinal then can wear off in a couple hours after surgery, and you don't have the lingering effects of the general anesthetic, and it helps patients get up and start walking and getting around a little bit sooner.
So what type of restrictions do you have after a hip replacement?
So after a hip replacement, some of the restrictions that you have can be based off of the surgical approach that is used for the hip replacement. So you do want to verify the restrictions with the surgeon that does it for you and discuss that with them before surgery. The main one being where we talked about the surgical approach, where you go in through the back here. You have to avoid positions that can cause the hip to potentially pop out of the socket, because that's the one disadvantage into using that approach. But with an anterior approach hip replacement, we don't have positioning restrictions for you after surgery. You can again put as much weight on it as you want right away after surgery. Over the first several weeks, it's just important to get up and start walking safely as the muscles around the hip recover and start getting their strength back. As far as long-term restrictions, the only restriction would be is just avoiding any kind of high-impact activity. High-impact activities can put extra stress on the implants, and so we tend to tell patients to avoid that to help with longevity.
Are there any lifetime restrictions after hip replacement?
Yeah, so the high-impact activities would be the lifetime restriction that we give you. Most of the patients that I tell that to chuckle a little bit and say that they don't run right now anyway. So it's the high-impact stuff, walking, hiking, all that kind of stuff is totally fine. It's mainly running and jumping would be the high-impact activities that you want to try to avoid.
So what are some of the complications that you could have with a hip replacement surgery?
So there are, fortunately, the complication rates with most of our joint replacements are low, but there are complications. With any joint replacement, the big one we always worry about is infection. We do a lot of things to help prevent and avoid the infections, but it can certainly happen. Other complications more specific to hip replacement surgery would be instability, where the hip pops out of socket. That's another advantage of an anterior approach. It has a low dislocation rate. Fracturing around the implants, that can happen both during the surgery or after the surgery. And that most commonly occurs around the stem through here. All in all, it's rare again, but if it does happen, sometimes there has to be another surgery done to treat the fracture around the stem. Other potential complications would be, we talked about getting the leg lengths correctly reproduced. Again, with the anterior approach, we can verify that with our X-rays intraoperatively and kind of double check that. But that's sometimes, in order to achieve appropriate stability in the hip, we do have to add a little bit of length to the hip. So that's another potential complication. And then just with the surgery itself, there can always be damage to nerves and vessels in the area. but again, fortunately, all the complications are pretty rare.
So what are some of the things that I can do before surgery to help decrease infection or complications after surgery?
So, again, like I said, we do a lot of things to help, especially infection. We do a lot of things to help prevent infection. Patients, basically kind of how we classify these risk factors, mainly for infection, is into modifiable risk factors and non-modifiable risk factors. So obviously anything that's a modifiable risk factor, we want to do everything we can to make it as good as we possibly can before the surgery. So for example, diabetic patients, we want to make sure that their blood sugars are under good control. The hemoglobin A1C is a blood test that basically gives us the average blood sugar level over the last 3 months. And so with that lab test, we want to have our patients with a value that's 7.5 or less. Kind of tells us that their blood sugars have been under good control for the last 3 months. Patients that are overweight tend to have more problems with wound healing complications, infections, even be a more difficult exposure and higher risk for fracture during the surgery. So we do try to have our patients work on weight loss beforehand. So with weight loss, we use a number, BMI, body mass index. Basically, that's a kind of a ratio between height and weight. And we like to have our patients 40 or less to have a joint replacement. Smoking is another big one, and again, that's another modifiable risk factor. So simply having patients quit smoking can help decrease the risk for infection and wound healing complications. We like to have patients not have any kind of nicotine products. I did specifically say smoking, but it's really any kind of nicotine can increase the risk for complications. So we like to try to have our patients not have any nicotine within 30 days of surgery. And the reason it's why the nicotine is one of the things nicotine does is it causes the small blood vessels that your body uses for healing. It causes those vessels to constrict down. So not using any nicotine products just helps promote blood flow, helps promote wound healing, and can help prevent infection. The other thing is to help prevent with infection is we like to want our patients to basically be infection free. We don't want them harboring any infection anywhere in their body. So of course we don't want to have any active infection anywhere as far as cellulitis or skin infection. Cellulitis, skin infection, we obviously, if you have any open wounds or anything near the surgical site, that can be a problem in harbor infection. The other place, and we don't want to have like any symptomatic UTIs, anything like that, but the last place that sometimes people can harbor infection and not even really know it is they can have infections around their teeth. And so sometimes we will have our patients see their dentist before surgery. If you have fairly routine dental care, you may not necessarily need to actually go see your dentist before you have a joint replacement. But you know, if it's one of those things you haven't seen a dentist for a while, especially if you're having any symptoms at all, like tooth pain, certainly having that checked out and making sure there's not an active infection can be helpful. So like I said, we just want the body to be totally infection free prior to surgery.
How long is recovery on hip replacement? Or did you already address that?
We talked a little bit about kind of the typical recovery. So everybody recovers at their own rate, kind of depending on, you know, strength and function before surgery is going to help predict recovery afterwards. And also the other thing, as far as how long does it take to recover from a joint replacement, it kind of depends on, you know, what the criteria you're using to define recovery. So typically after joint replacement, like I said, our goal is to even have you up and walking the same day of the surgery. You know, like I said, typically with anterior approach hip replacement, I'd say on average it seems like most patients use their walker for about 2 weeks and then start transitioning to a cane, and then around 4 weeks or so they're getting rid of their cane. And by 6 weeks, hopefully getting around, pretty well. I've had some patients go back to pretty physical jobs around the 6 week mark. But everybody recovers at their own rate, and I've had some patients that recover even quicker. So that's just kind of a rough average, I would say.
So are hip replacements an inpatient surgery? Do you have to stay overnight, or if I want to have surgery, can I go home the same day as my surgery?
Yeah, so that's one thing. Even since I've started working at Great Plains, and also thanks to Jill here, we do have a really good joint replacement program, and we've steadily been decreasing our length of stay. There's just a lot of kind of rapid recovery protocols that can be used for joint replacement surgery, and it's just naturally, 3 to 5 years ago, it'd be very common for somebody to stay in the hospital 3 or 5 days or more. Our average length of stay here is 1.5, right, Jill? Yeah, so it's people are going home sooner and sooner, and it is getting to the point now where it's safe for patients to go home the same day of the surgery, especially if they don't have many other comorbidities or many other health problems. If they're otherwise healthy, in good shape, it's now very reasonable to go home the same day as your joint replacement surgery, both hips and knees. Anecdotally, to me, it seems like hips are a little bit easier from that standpoint. But that's just kind of with the protocols that we're developing here. Yeah, doing it the same day is very reasonable, and even to be honest with you, in light of the coronavirus pandemic, avoiding an inpatient hospitalization may be beneficial. So we have been doing more and more outpatient surgeries where people go home later the same day.
With a pandemic, if you are needing a joint replacement right now but you don't want to have the surgery because of that, what are some of the things that you can do to prolong waiting, like injections or physical therapy? What are some of those things that a patient could do to not have surgery right now?
Sure, yeah. So as far as conservative treatment, for hip and knee arthritis, the kind of mainstays of conservative treatment will be Tylenol, anti-inflammatories, low impact exercises, keeping as much strength around the arthritic joint as possible can help relieve some of the symptoms. Weight loss can be helpful. There's a direct correlation with not only the other advantages of losing weight, but just actually losing the weight takes the stress off the joints and can help the pain. We do also do injections. Now, there's a lot of different kind of injections out there when it comes to arthritic joints. Corticosteroid injections would be the most common injection that we do, the ones that have been around the longest. And basically, how the corticosteroid injections work is the arthritis or the wear and tear process within the joint is a very inflammatory process, and some of the pain is coming from the bone and bone wear on the cartilage, but some of the pain is also coming from just the intense inflammation that's within the joint. And basically, the steroid injections are just a very powerful anti-inflammatory that's right inside the joint. So a lot of times we give patients good pain relief with the steroid injections. Other injections that you may hear about, are hyaluronic acid or HA injections. Some people refer to them as a rooster comb injections. That's where they get the substance from. We do occasionally do those. It's kind of a patient kind of specific whether or not it's worth trying those. They are more expensive, and their overall efficacy isn't much better than just a regular steroid injection. Another question we commonly get from an injection standpoint is stem cell injections. Most stem cell injections, are going to be an out-of-pocket expense, And again, if you kind of look at them as a whole compared to steroid injections, they don't really work a whole lot better than steroid injections. So we tend not to routinely use those either. The other thing that you have to be a little bit careful of with the steroid with the stem cell injections is some of them can not be safe, so you just have to be careful where you're getting your injection and exactly what they're doing for you before considering doing that. Again, they are an out-of-pocket expense usually, so not something that we typically do here. Let's see here. Otherwise, sometimes simple knee sleeves can be helpful for knee pain and knee arthritis. There are some other specialized braces that work for some patients, not for others. Activity modifications, important, avoiding painful activities, and then even using a cane to help offload the joint can be helpful.
So if I get a steroid injection, how long would I have to wait until I could have surgery?
Yeah, so that's a good question. Something you have to keep in mind if you do consider a steroid injection. So we have to wait at least 3 months after having the steroid injection before we do the joint replacement. And the reason that is because, again, the steroid is an anti-inflammatory. It kind of down-regulates the body's immune system, the response of the immune system. So if we do the joint replacement within 3 months, it decreases the body's ability to fight off infection. So if you do the steroid injection, we'll wait at least 3 months before we do joint replacement surgery.
So I don't think we have any other questions right now. Is there anything else that you want to add before we let you go back to patients?
Yeah, like I kind of mentioned before, this as far as doing joint replacements, again, I think we have a very good program here. A lot of it is thanks to Jill, but it is very much a team approach, and but we're always doing things to improve this, and I think the newest thing that we're going to be doing to improve things is going to be more outpatient joint replacement surgery, kind of like we talked to. And the coronavirus pandemic is kind of pushing us in that direction a little bit, but thankfully we did have a lot of these kind of rapid recovery protocols, and we were kind of moving in that direction anyway. But I think that's something else we're going to be able to offer people and kind of help them, especially with everything else that's going on.
Okay, well, thank you for your time and all the information. For people watching on Facebook, if you have any questions we didn't answer, put them in there and we can have Dr. Correll address them later. Thank you.
Thank you.